right, good evening, everybody. My name is Justin Lucas. Welcome to our AO Trauma Journal Club series discussing practice influencing articles. I'm from San Jose, California. I'm an orthopedic trauma surgeon. And tonight we have some very distinguished faculty from our AO Latin America contingent, Dr. Rodrigo Pesantez from Bogota, Colombia, and Dr. Eduardo Carrillo from Cali, Colombia, who will be helping us discuss a series of articles. Here are the financial disclosures for the faculty. This is an event that is eligible for CME credit. You can log in if you have completed attendance at the series and will be sent an evaluation questionnaire after which you can claim your CME credits. Just as a reminder, AO North America is an independent, nonprofit specialty society. None of the products or services that you may see from commercial entities are endorsed or promoted through this experience. And anything that you would see in our event tonight is for demonstration and teaching purposes with the intent to enhance the learning experience. So for the evening tonight, we're going to review some current articles. They'll be focused on things that have changed people's practices, things that we are very proud of to have contributed to, and then also some areas of innovation or different schools of thought in the worlds of fracture surgery. And then hopefully we can generate some live discussion based on the audience participation. Here's our agenda for the night. Again, several articles after our case discussions, and I think we could go ahead and jump right into things. I will turn it over to Dr. Rodrigo Pesantez at this time to share our first article that is related to something practice changing.
Sorry. So thank you very much for your kind invitation. It's great to be here. So the first article that changed my practice is this article from Argentina. The authors are Dr. Sublin and Dr. Beadi from Buenos Aires, and then Dr. Giordano from Brazil. It was published in Injury in 2023, the English version, but there's an older version in the Revista Argentina Traumatología y Ortopedia. So what is the problem with posterior tibial plateau fractures? Several classification shows that the posterior columns are very difficult to treat. And not they are difficult because their visualization is very, very hard. Even for the different approaches that we have heard from the medial side of the hover, lateral side from tricky, all these approaches has limited windows and they're very small. You need to make a long skin incision, but the windows to work through are really difficult. So in this study, this is an observational retrospective study that has 18 isolated posterior tibial plateau fractures between 18 and 75 years old with a follow-up of 12 months. So what they describe is the surgical technique, basically, and they use the floating positions just in case that they need to go in the front for whatever reason. And they have two skin incisions, one that is midline and another one that is similar to the reverse L of confident glue, in case you need to go more towards the medial side. So the advantage of this one is that you will have three windows, a posterior medial, a window between the both gastrocnemius and the posterolateral window. So this is a case, this is a lady, 27-year-old, that you could see that all the posterior components are fractured. So you have a split on the posterior medial side and then some impaction in the posterolateral corner that are difficult to go, and the posterolateral central fragment is very difficult to reach. So these are the two articles, and feel free to ask for this at the end. So the one on top is the one that the first description in 2022 in Spanish, and the second one is in Injury in 2023. So again, those are the x-rays of the lady that I just showed you. So you could see it's basically a flexion mechanism that has the posterior columns involved. You see here some cuts of the CT scan, and now you will see later right here the movies of those injuries, and you could see the split on the sagittal split on the medial condyle, and then of course you see here on the 3D reconstruction all the impaction in the posterolateral central region of the tibial plateau. So this is how we position the patient. I decided to put this patient's prone since I'm not going to do anything in the front. And you see, I get an AP like this, and I get a lateral view like this to make sure that we have a good assessment of the implants as well as the reduction technique. We follow exactly what Dr. Beati and Dr. Sublin described in 2022. So you could see here the skin incision. You can see the flexion crease of the knee, and then the long skin incision. I started to do this approach, and I decided to do a longer skin incision so I have very good approach so I can see the medial, the central, and the lateral windows and work through them to this approach. So you could see here the skin incision and the fascia. Now you see the both gastrocnemius and then the nerve and the vein. Now we split from proximal to distal, and we identify the neurovascular bundle, and then we look for the medial arteries, and then we clamp those so we can mobilize easily the neurovascular bundle and protect it. Here you could see how we get the reduction. We put a small plate to reduce the posteromedial fragment, and with some K-wires. Then we apply through the medial window this plate, similar to the Lovenhofer approach. And now we work through the central window as well as the lateral window, so I can reduce the pressure on the posterolateral corner. And as you could see on the picture on your right-hand side, we can insert the suction so we can see the back of the joint and assess our reduction. Now you could see here the reduction, and here you could see in the central window that you could see the medial plate as well as the ring plate that we use on top of that. Here you're seeing the Lovenhofer window towards the medial side, and here you see the final fixation of this injury. Here's the postoperative x-rays. So what is the protocol that they describe? So this early mobilization on the day of surgery, they start immediate range of motion, and the wide variant is tolerated at around a month and a half after the injury. So we keep restricted wide variant for the first month and a half. What they had is 16 Schasker-Kifuri 4, 5, and 6 fractures. The average time was 179 minutes per surgery. And the knee society score is 85, and the average day to return to work is around 192 days, that's around 6 months to go back to work. They have 4 patients with complications, mainly with wound and some intra-articular issues. What they said at the end is that you have an improved visualization and a safe mobilization of the neurovascular bundle. You can put the implants parallel to the main fracture plane, and you have 100% return to daily activities. What is good is a single approach with a full exposure of 3 windows. There's no other approach that can give you this variability that you can work through 3 different windows. If you do the reverse L, you have probably the middle window, and then maybe you can catch something from the middle side. If you do the lateral approaches, Lovenhofer, tricky, or flush, or whatever approach on the lateral side, then you have a small little window there, but there's no way that you can work through the 3 windows at the same time. The disadvantage, this is a retrospective and a small sample size, but the good thing is that you have a direct visualization of the popliteal vessels, and then you can have a safer approach. So at the end, what you find, what is the clinical impact outcomes, is a satisfactory reduction with an enhancement of the biomechanical stability. What are the challenges and solutions? You need to understand the neurovascular anatomy, and actually he quoted in one of the reference the anatomy and the different vascular kinds that you could have in the popliteal vessels. And then the implementation and collaboration definitely is a teamwork and standardize a safe, ensure a safe adoption. This is an approach that they have been doing for a long time. And now a lot of places in Argentina are doing this. And here in Colombia, we started to do it a few years ago. And actually, we use it not very often, but it's an approach that is useful when you have all the posterior components fracture and the anterior components are intact. Is very, very useful for these kind of fractures. Thank you very much. Justin, go back to you. Stop sharing my screen.
Thanks. I think that's a really fascinating article. It discusses a problem or um, an area that we know there's no go-to solution when addressing certain fracture patterns. So I guess when we think about something like this being practice changing for you, what are your indications to use this approach, and to what degree have you actually incorporated it into your routine fracture care?
Yeah, Justin, I'm old enough to have, when I started, they were doing just basically midline incisions in the front and the Mercedes type incision. I saw all the evolution of the approaches of the tibial plateau. And the understanding of the columns since Confront Glue in 2010 have let us think in a different way of the approaches that we need. And now we are able to approach the new 360 degrees. The use of 3D CTs and the CT scans allowed us to see what are the fracture mechanisms that we need to address. So to answer your question, what I look on my CT scans is if I have a flexion type of mechanism that has the anterior columns intact, then I know that I need to go from the back. And what I look on the axial CT scan is how far they go. It's similar to what you look in the posterior mouth. So you see if it is in the posterior lateral, if it's in the posterior medial, if it goes all the way. If it goes all the way, most likely I will try to use this approach, Justin. If I have something that is just the posterior medial, then I go to the Lovenhofer. If it is only posterior lateral, then I probably use a tricky or a Froch approach. But if you have, like in this case, all the components, posterior lateral and posterior medial, then I think this is a very useful approach. And we have incorporated this approach in our place for those kind of fractures. See, if we have a fracture that goes in all the posterior column, lateral and medial, then we try to use this approach. And it's very useful also for fracture that are in the blind zone that Forge described. So the lateral central part that is a blind zone, regardless of where you go, this is a very good approach to go to that place, Justin.
Excellent. So I think we spend a lot of time trying to differentiate between two ways to do surgery. One is to stay safe and protect ourselves from neurovascular dangers, for example. This paper seems to advocate for exactly the opposite, where we would go and identify those dangers very early on and then work around them safely. What do you think about conceptually is the actual technical demand to become proficient in something like this?
Justina, actually in the attendees is Miguel Sublim, who was the author of this. And the first time I asked him, and he said, look, I give you the article that shows all the different variation of the anatomy. And then the key is to go to the genicular arteries and try to find the medial one and clip it. And then you can mobilize the vessels easily. It's like going in the posterior parts of the humerus. You need to know where the radial nerve is, you identify the nerve, and you work around that. So I know it's not easy to go straight that way and look for the vessels, but once you find them, you basically protect them and you're seeing them all the time.
Do you have an interesting question here? What
Yeah.
about Lobenhofer approach with medial gastrocnemius proximal tenotomy? Do you have any opinions on that?
So Pierre, thank you for the question. I haven't used that combination to tell you the truth. So maybe I'm going to look around that too. but I have no experience with the tenotomy of the medial gastro, Pierre. I don't know, Eduardo, do you have any answer to that?
Yeah. Good evening. Thank you very much. Yes, I've tried a few cases, and it's true. If you do the tenotomy to the gastrocnemius, you can expose a little bit more the lateral side, even through the direct Lowenhofer posterior medial approach. But you have to repair it later, no? So if you're going for the tenotomy, you have to do that later. Even so, through that approach, the one that you described, Dr. Pesantez, you can also expand a little bit more by doing the tenotomy if you reach the upper anatomical region. So the important thing to keep in mind is to reattach the tendon.
And you know, just in the advantage of doing the Lowenhofer, as Pierre mentioned, is that basically you are protecting with the gastroc and the soleus all the neurovascular structures, so you don't see it. The problem for me is trying to get some grafting on the lateral side in case I need it. So you can buttress the lateral side, but you cannot see the joint or try to do some grafting screws from the posterior medial approach. I don't know, as I said, I have no experience with anatomy, but the beauty of this approach is you can work through the three windows, and it's just identifying the neurovascular structures and work around them.
And then for both of you guys, how would you rate your ability to actually see the articular surface with an approach like this? Is it lessened, or is it equal to an alternative approach?
I would say for me, Justin, on the lateral side, you could get good visualization. The medial side is not that easy. On the lateral side, especially in the central part close to the PCL insertion, if you do a submeniscal arthrotomy, you can see quite good the articular surface. The other thing that you could do, I haven't tried that, but I used it previously on osteotomies, is put the femoral distractor and then try to distract some part of the joint, then you can enhance your visualization of the posterolateral part. But on the medial side, it's not that easy.
Justin, and I think that it's an anatomical factor. Remember that the medial side is a concave plate, so you have the condylar femur obstructing all this visualization over there, no? And that's why maybe the lateral side is a little bit more easier to see the surface because it's a convex surface, no?
Yeah, I agree. And then what about, it may seem trivial, but when we do have choices, I think it's important to try and be thoughtful with them. What about, have you guys noticed any differences in the actual skin incision, whether you cross the popliteal crease vertically or versus a reverse L type incision where you go transverse in line with the crease, things like that, as far as uh, patient recovery, complaints, range of motion, things like that?
Justin, I haven't, I would say probably all that I have done so far, I've done midline, and I try not to cross the crease, uh, maybe 1 centimeter mostly, not that far. So I have no experience doing this approach using the reverse L. How about you, Eduardo? I don't.
Yes, well, I've done maybe three, I think maybe three or four, thanks to you, because I've seen your cases. So I've done one L reverse, but I think that's an important anatomic issue to take into account, not to cross the crease. I haven't had any problems yet with scarring of the tissue, but do not cross the crease may be the tip, no, for this approach.
Awesome. Well, I think it's a very unique approach. The article highlights it well, and hopefully gives our participants, even myself, some food for thought when we're planning the next tibial plateau fracture. So let's move on now to our next article with Dr. Carrillo.
So, thank you very much again for this special invitation for me. The next article is called Outcomes of Cement Augmentation and Fragility Trochanteric Hip Fractures. This is a very special article because the authors, Dr. Olarte, and as you can see on the slide, also Dr. Pesantez were authors of this article. And I was able to do my fellowship with them in 2017, 2018. So I kind of like could have been in some of the surgeries in which these patients were studied. No, it's on the magazine Injury and it was published last year, 2023. And the two main institutions that worked with these patients were Fundación Santa Fe and Hospital Universitario San José. It's also mentioned Hospital Serena de Mar because one of the authors works over there. So one of the common complications of the fixation of these fractures in elderly people is mechanical failure. No, so we know that maybe the hip screw could suffer a cutout or a cut through, depending on the design and the quality of the bone. And it's been established that some techniques could improve those outcomes. You know, so we have the augmentation with cement, yeah, and that can improve the stability of the implant. The study design is a multi-center study. It was randomized, single-blinded from the patient view, and it was done in these two institutions that I mentioned in Bogota. They divided in two big groups. A group of patients of 65 and 85 years old, yeah, the young group, the younger group, and an older group, more than 85 years old. They did a stratified randomization strategy. That means that for each group, they put a block of 6 patients, 3 with no augmentation, 3 with augmentation techniques. And finally, they managed to study 90 patients. So they divided at the end 47 patients for a standard fixation and 43 for augmentation technique. They followed the patients for 7 years, and the primary outcomes that they wanted to evaluate were changes in the tip apex distance, and the secondary outcomes were two kind of functional scores. So how they evolved in that aspect. Of these 90 patients, at the end of the follow-up, the result was for 53 patients. They lost the follow-up in the course of those 7 years. And for the first outcome, the changes in the TAD and the tip apex distance, they found it that really there wasn't any differences between the tip apex distance. In the immediately post-op, the mean measurement was 21 millimeters, and a year later, 20.9 millimeters. So really the difference wasn't big, no? And in the group of the elderly, the more than 85 years old, they also then find a significant difference between the groups of non-cemented and cemented, as the same in the younger group, the 65 to 85 years old. So the differences really wasn't significant. In terms of the secondary outcomes, the functional scores, they evaluated at the first, 5th year, and 7th year. So the main difference, they saw it in the first year, because at that first year, most of them returned to a pre-injury level with these scores. Instead, years 5 and 7, maybe well, there was a great difference, but it seemed that it was a kind of like a caused because of factors of aging. Complications that emerged during the study: 13 readmissions, but were 10 non-related to the fracture and 3 related to the fracture. 2 of them, one in each group, presented a cut-through complication, no, a mechanical failure. 17 deaths during the 7-year follow-up, non-related to the fracture. So, what we managed to find in this article was that even without augmentation, the TAD didn't change in an important fashion, no, and that may be correlated with other studies. The functional assessments didn't vary much at the first year, but at year 5 and 7, maybe due to the aging issues, there was a little change noticed. Main limitation of this study was that although they had 90 patients to study, the dropout was important, no? So just with only 53 at the end. So augmentation techniques may be a way to improve stability to the construct. But in this article, especially, we found that it really is a safe procedure. Maybe it could take a little bit more time if we don't use the augmentation technique. And the functional outcomes really didn't differ, no, between one group or another. I'm going to share 2 cases. This one was one of the cases that I participate when I was doing my fellowship at Fundación Santa Fe. So we can see an intertrochanteric fracture. And these are the fluoroscopic views of an AP and a lateral view. The technique, the standard technique to insert the nail at the tip of the trochanter, positioning the guide wire centrally in the head. So when the blade was blocked, that was the moment when the crew opened the envelope and they were told if they had to augmentate or not. In this case, there was an augmentation procedure, and these are the final results. And I wanted to share a second case, just in case people want to explore this technique. This is another intertrochanteric fracture, maybe a basicervical fracture. Same AP and lateral view. So when the blade is put in, you have to expose the joint to a contrast. So you can see that there's a spillage. There's some spillage of the contrast in the capsule, no? And this is what you have to avoid, no? Not to be attent to the spillage. So remember this image if you're going to use this technique. If there's a spillage, it's better not to augmentate, no? So maybe this technique could decrease complications, but looking at the results, at the outcomes, the differences between both groups really isn't much, no? So I think that if you're going to use an augmentation technique of this type of fixation, maybe you have to pick the right patient for it, no? Quality of the bone may be one of the most important issues to take into account. There's no doubt that this is an advance in this kind of surgical techniques. And one of the important limitations of this study is that the sample was really small, no, at the end. And maybe we could do another study with more patients, no? Thank you very much.
Yeah, thank you. I think that's a great study. I would also be very proud of that. And it's one way to make surgery exciting is have an envelope to open in the middle of the case.
Yeah.
But having participated for both of you guys in that work, what's their influence or the lasting impression it leaves on you as far as how you decide whether or not to use this technique now?
Well, in my practice now, I really, and maybe I can say based on this article, because a year with my teachers and mentors, uh, being exposed to this technique is awesome because it's a novel technique. But by that time, no, using this implant, but looking at the results, really since my fellowship, I maybe used that technique once, but the rest I've just did the standard fixation. So the experience for me was, or the great experience for me was to see how a study can be achieved by great teamwork. No, that's maybe the most important thing that I can take about this procedure. No.
Yeah. Oh,
This 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 study is very close to my heart because we applied to the first international grant of the OTA. So we applied to this one and we won the OTA grant to do this research. And it was the first one. It was the first randomized control trial that we did. The beauty is that we only use one implant. We have randomized all the cement. But at the end, even we try hard to see when do we need to be sure that we need to use the augmentation. Probably we need to do a subgroup analysis, but we don't have enough patients to see that the severe osteoporotic, the very elderly patient, probably above 85 years old, uh, would benefit from this augmentation. You know, the new studies from Germany, from Lander, showing that cost benefit is better that you augment most people because every failure costs more than the cost of augmenting every single fracture. But to tell the truth now, what I use is mainly in severe osteoporotic patients. We augment some of them, and in patients that we see that the position of the implant is not the best. So those are mainly the two things that we use nowadays, Justin.
so I think those factors are interesting. As my actual next question for you was going to be, when you do this, to what degree of the cases that you're using augmentation in, is it premeditated as part of your plan going into surgery? And then how often are you deciding to do it because of a factor that you see intraoperatively?
I would say probably in my case, Justin, if very elderly patient, probably above 85, 90 years old, we think to have the augmentation ready. Um, and I think on the study also, I think that the bias is that we knew we were doing the study, so we were very careful with, even more careful with the reduction and positioning the implants. So probably that's a bias on that study. Um, so yeah, that's it. And now I probably basically see if the patient is very old or if intraoperatively, for any particular reason, I cannot have my excellent reduction and a perfect position of the implant.
Yes, and I think another factor that's important to take into account is that, well, in our countries, not all of the clinics or hospitals, no, can have these implants right on time, no, and we know that these kind of fractures are an emergency. No, you have to operate them in the first 24, 48 hours at best, no, but sometimes it's very hard to grab to take the this kind of implants, no. So that's another factor that limitates maybe the practice of the common surgeon here in Latin America, no.
Yeah, it's interesting perspective. I think that's important for everybody to have. That sometimes you can't do it even if you wanted to. So, but your paper shows that maybe it may not be as necessary as we think, as far as the final outcome. So that's really nice. To keep going, the next topic will be a little bit of innovation, or maybe outside of the box thinking. Back with Dr. Pesantez.
Thank you, Justin. And I'm going to be giving the whole credit to my very good friend Miguel Sublin, because this is something that I hadn't used, but I think a very, very interesting concept for long bones, severe long bone defects. So this is a study again from Buenos Aires, from Argentina. It's published in La Revista de la Asociación Argentina de Ortopedia y Traumatología in 2022 by Matías Beati and Miguel Sublin. This is a retrospective observational case series. It's a very small series from 6 patients, 5 male with massive bone loss treated what they call a synergistic combination and an induced membrane to provide biological benefits, plus a trabecular titanium scaffold designed for each patient to provide stability and structure. And what is interesting to me is once they have everything clean, they do that on one stage. The average age of the patient is 30 years old, and the follow-up is 2 years. They basically restore axis length and provide mechanical stability to allow patients to do partial wide bearing from day number 1. So let me show you a case that was given to me by Miguel Sublin. So this is a 21-year-old male who had a motorcycle accident. He is a drug addict and had an open proximal femur fracture 4 days before. He got in another place, did an irrigation of the debridement, and got an X-fix. And 7 days later, he got an intramedullary nailing, and 3 months later, he came back, draining with the cultures positive for Staphylococcus aureus, methicillin resistant, and they did an exchange nailing at cement, and then the patient was lost to follow-up and came back a year later. So those are the initial X-ray, quite a, let's say, simple proximal femur fracture with a comminution, but it was open. So this is the day 7, what they did. So an open reduction, that's your clash to hold this butterfly fragment, and then this nailing. And that's when they came back again. A year later, he has been in clinic at 3 months with an Staphylococcus aureus, but then he was lost to follow up and came shown with this infection. So what they did is did an irrigation, debridement, put some beads inside, and then they change it, remove all the dead bone, and put a new nail with some bone cement block to have like a kind of masculate technique. And what they do, this is the interesting part, Justin, because what they use is all the preparative planning to have a correction of the entry point for the angulation and the osteotomy that they need to do. And they do all this using 3D and using preoperative planning on computers, which is outstanding. And they use tomographies and they use the normal side to get back and reconstruct not only the length, the alignment, also the anteversion, as you will see on the next slides. And as you see here, they have 23 millimeters of shortening of the leg. Here you see that on the normal side, we have a CCD of 135 degrees on the right side and 115 degrees on the left side. So it's inverse. And you could see the anteversion on both sides is 7 degrees of retroversion in the left side. So what they do is mirror the right femur and then align the proximal and distal segments, correcting everything. All these are done on computers, and they do the implant design. And as you could see there, what they're going to use is a new nail, and they use, in blue, you could see the titanium shell. In green is the porous titanium structure that they are going to use, and in red, the bone grafting that they're going to have in there. So they plan the cutting, so they have a flat surface that they can put the titanium mesh inside once they have the length of the nail. So here you could see the porous structure and the medial window that is going to connect the both segments. And you see on the right-hand side, on the bottom, you see the titanium mesh. And this is the planning. So they have to fix this with some screws or plates to hold this in place while they have this one. This is a 3D printed model, so they can plan the whole position of the implant and the cuts that are going to have. Here's clinical pictures. So they have all these, and I'm going to go back. So they have these previous molds that they can use intraoperatively, so they can have this. They cut it, and as you see on the picture on the top right-hand side, you see the measure of everything, and now you see the titanium mesh in the bottom left, and then you see the titanium mesh with the bone graft in. Once they do the cutting of the segments, they put the titanium mesh and fix it with some K-wires, correcting the valgus that they have. So put it into valgus and get the length right there using the ruler of the nail. Now they put the nail in and some screws, the same as planned, to fix the titanium graft to the proximal femur. And then in the distal part, they add a plate so they can have this like a anti-glide plate, and they also have a screw on the titanium mesh to fix this one. Now you see here the use of the femoral distractor, the nail, and the titanium mesh inside. This is the immediate postoperative X-rays. And this is 9 months later, and you could see the patient walking straight ahead. It's still a little short, 1.5 centimeters short, but it was 3.5. And now you see here, 3 years later, and the integration on the medial side, you have all the bone that is surrounded this in the medial and posterior cortex of the femur, and the titanium mesh, it's perfect. You could see none of the screws of the nail has broken. And here is the clinical results of that patient. So what they have in this is that the management of long bone defects can be really challenging, and the use of these alternative techniques is feasible as long as the biological and mechanical conditions are planned, and it is a reproducible techniques that shorten the number of reoperations and recovery time in a very young patient.
That's fascinating. I think the different topics in that article could each be their own webinar, from, bone defect management, deformity correction, uh, implants, you name it. And so I've never seen anything like that done and put all together kind of as a package. And so having the experience and knowing the authors personally, what do you think is the indication for this particular treatment plan? When is this something that we should think about as far as dealing with these problem type fractures?
Justin, I've seen the authors, and they have now a longer series. Even they're using in different hospitals in Buenos Aires. They already have some person that have all the technology to do this at an affordable place, an affordable price, especially here in Latin America. That is very important. The cost of all this, and this will decrease the cost of on the long-term treatment of the patient, because the cost that you pay for the titanium and all this planning, it's is cheaper than if you have several interventions for these patients. Basically, what they do is use in long bone defects about probably 6 centimeters, and they have very good experience. Now they're using that in different places. There's another place, Sanatorio Guimes, with Fabricio Videla, and in some other places in Argentina are using this technique. So for me, it's a promising technique. I haven't used that one. We don't have the technology yet in our country to do all these pre-planning and all this titanium mesh 3D printed, so we can have it here. But I think it's something that in the future is gonna be part of the armamentarium to treat long bone defects on patients.
Do you have any experience with these techniques, Eduardo? Or when you see a paper like this, if you don't, are you inclined to incorporate this quickly into your practice?
Yeah, well, I'm very amazed with this paper, no, when I had the opportunity to review it. And I think, well, not yet. I haven't done this kind of surgery, but I think this is a huge step, very huge step for personalized medicine. That I think that's has to be the future, no? Because we're making implants according to the patient's characteristics. So maybe something to think about so everybody can work on it, no? And the advantages of, as Dr. Pesantez said, no, with the paper, no, one single stage, no. I've done Mascalet techniques, and he's right, no. You have a patient maybe 1 year, 2 years, yeah, depending on the bone defect, no. But with this, probably we're going to see better outcomes, no.
Justin, Michael is asking online that what are the benefits of this novel technique over existing non-articular bone defects management, and what are the concerns? And Michael, it's I think the there's no study comparing, bone transport, masculate techniques, or the different solutions that we have for long bone defects in non-articular. I probably would think that would be really interested to compare the outcomes once they have more follow-up from the series in Argentina with other series using different techniques. I have no other answer than that, Michael. And the concerns probably for me are the cost, but as I talk with my friends in Argentina, the cost at the end on the treatment is cheaper because they decrease the amount of interventions that they have to do in those patients.
From a logistical standpoint, are these truly locally sourced custom implants from local vendors in the area, or how is the development of these custom implants going about to allow for these types of surgeries?
What I hear from them, Justin, is that they have a local vendor that they use to do for several defects. Even they're using some of them to do some cups for acetabular defects in total hip arthroplasty. But now they started to use it in trauma probably 6, 7 years ago, probably more, using that 3D printing, and it's local sources and local companies who are doing this.
Yeah, I think one of the biggest advantages when I see this is over other techniques that may not be transport type techniques or heavily require other implants or multiplanar frames, things like that, would be the ability to have immediate structural stability to allow for that weight bearing or increased activity earlier on.
Yeah, I think, and the concerns of coming back to Michael's question is probably, I don't know what is going to be at the end with the titanium mesh. They have probably, I think the longest that they have is 5, 6 years follow-up. So I don't know really what it's going to happen with the titanium mesh in the long term, because most of these patients are young patients.
And I think we usually see these sorts of techniques applied to the long bone lower extremity injuries. Do you know, has there been any experience with utilizing these techniques in the upper extremities?
Not that I know, Justin. I think most of the cases they have in Argentina are lower extremity. I'm not aware of any upper extremity.
I think it's awesome. It's nice to see some interesting things like that. We have one more article. to go through. So I will give it back to you, Dr. Pesantez, for a practice-changing article to finish off the series.
Perfect. Thank you so much, Justin. So for me, it is I have the pleasure to know the author of this article. I met him in 1999. Probably you weren't born yet, Justin, at that time. So this is an article that was published in 2004 by William Diaz Belangero and Bruno Livani in Injury. Both of them work in Brazil, in Campinas. And what they did is they have 15 patients between 14 and 16 years old with 16 humeral shaft fractures with a follow-up average of 28 months. Basically, they use DCP plates, 12 holes, 2 to 3 cortical screws on each side. At the beginning, they were using 3. Later on the series, they used 2. All of them healed at around 12 weeks, except one open 3. That patient had an open 3 injury and a brachial plexus injury at the same time. So here you could see all the different patients that they have. Most of them are type C fractures, but also you could see some type A and type B. And here you see that the healing time, the only one that didn't heal is patient number 11, which is the one which has the open fracture and a brachial plexus injuries. But most of them healed, and you could see that they heal in average 5 degrees to varus to 10 degrees of valgus, but the range of motion is absolutely fantastic. What is the technique? Which is very useful and it's very simple. Actually, William, when he started, he didn't use at all X-rays. So now what I use is supine C-arm and the hand on a radiolucent table, and then do the arm in abduction about 60 degrees to correct the varus, and then the forearm in supination to have the radial nerve away, then some traction, and the distal fragment to correct the rotation. You have to have the condylar axis orthogonal to the biceps tendon. And this is a clinical picture of how you should do it to get the reduction of the humeral shaft and the alignment. So William described, and those are pictures from William Belangero, the two approaches. The one in the top is for mid-shaft fractures, 12-hole plates, and the one in the bottom is for more distal ones where you twist and bend the plate a little bit towards the lateral column of the humerus. And if you do that, then you need to use the cochlear approach for the distal part. We're going to focus on the mid-shaft technique. So the anatomical basics, they have 2 windows, one in the top and one in the bottom. The one on top is between the deltoid and the pectoralis major muscles. You basically split these 2 muscles proximally, and then distally, you come and identify the biceps muscle, and you come through the biceps muscle and take the biceps muscles toward the radial side, and then you see the brachialis and the musculocutaneous nerve. The musculocutaneous nerve you have to respect, and then you basically taking into account that the brachialis has dual innervation, you split the brachialis in the middle. One very important tip is try not to use Homan retractor, especially on the radial side, because if you put it on the radial side, you can injure the radial nerve. So try to use right angle retractors all the time. Once you have these 2 structures, then you see here, you split the radialis, the brachialis, and then you are basically straight into the humerus. And the anterior part of the humerus is basically flat, so you can slide the plate. Here's some good pictures, courtesy of my friend Miquel Videla from Barcelona. So proximal, you could see the different windows, and that's in the mid shaft, so you can see the relationship, the radial nerve and the median nerve with the anterior surface of the humerus, and this is distally, so you can see the brachialis and the shape of the humerus. Here's a case, a gunshot injury, and you see the different windows. On the top and the right-hand side, you see the proximal window. In the distal part, in the center and in the top, you see the musculocutaneous nerve. We have taken the biceps muscle towards the radial side, and now we are seeing the nerve, and we take care of the nerve and split the brachialis, and you see in both, in the bottom, the plate is slide. You can slide the plate usually from proximal to distally and fix one of the screws proximally, keep it loose, make the reduction maneuvers, and fix the other side so you can assess this one. Initially, as I said, William didn't use any C-arm. I used it from the beginning to just to assess the reduction in both the AP and lateral. Here is the result of that case. So this case, as you see, two screws divergent amongst them, and this is the follow-up and the clinical pictures of that patient. So what are the results that they presented? 16 humeral shaft osteosynthesis, one non-healing fracture, that's the polytrauma with an open fracture grade 3A, and 2 cases with varus deviation. There's no risk of a iatrogenic lesion of the radial nerve because of the anterior position of the plate. The only concern that you have is distally, do not use Homan retractors because you can injure the radial nerve. It's a bridging plate. It's better for type C fractures. And in this study, only 4 patients had a type C, but all fracture healed except the one that I mentioned, the open fracture with a brachial plexus injury. One of the good aspects of these techniques is early range of motion. It's in supine position and does not require any special instruments or implants. So in summary, remember that you have a proximal window, a lateral border of the biceps and medial border of the deltoid, and the distal window is between the biceps and the brachialis, and then the biceps towards the medial side, you split the brachialis, taking into account the musculocutaneous nerve. Thank you, Justin.
Awesome. So I was born in 2004. I wasn't doing surgery yet, but being that it's been 20 years and this was a practice-changing article for you, does it still have the same influence, or does it still hold true for you today, or have you evolved from what you learned from this article and changed that to a way that you think's better, or?
You know, Justin, the question always in humeral shaft fractures comes from, I'm from Colombia, and Eduardo's Dr. Sarmiento was born here. So I grew up knowing non-operative treatment of humeral shaft fractures. Then we moved to retrograde nails in the late 1990s, and some complications breaking the distal humerus, and then antegrade nailing, the old ones, and then some complication with range of motion of the shoulder. So we were very used to do open plating, especially anterolateral posterior approaches. When I saw this one from William in 1999, and he showed me all his anatomical studies, I was delighted. And I started to use it. In my practice, I still use it, especially in type C fractures. Usually type B and type A, I rather use an anatomical reduction of the type B fractures, of the butterfly fragments. And in the type A fractures, I rather use absolute stability and anatomical reduction. But for type C fractures, I'm still using that. I'm not a huge fan of nails in the humerus, especially antegrade nails. But my other 2 partners, they use nails for complex mid-shaft fractures. I rather still use some mepoplating in type C fractures.
Do you have experience with this technique, Eduardo?
Yes, yes, and in fact, I had the honor to know Dr. Belangero a couple of months ago, and his story of how he came with this technique is very beautiful. And in summary, it was kind of like the need of innovating in this kind of techniques by 1999, no? So and the way he tells the story is awesome. Yes, I have experience with this technique as Dr. Pesantez, and I learned it in my fellowship with him, and I also use it in type C fractures. Um, Sometimes I use nails if I don't have plates. It's very rare not to have plates, but in some cases I also use nails. But I really prefer in type A and B fractures open reduction, so I can see uh, all the structures surrounding the fracture. No.
Justin, there's a question that says, have you seen this human shaft technique used inappropriately or are the contraindication in my assessment? So yes, I have seen this inappropriately, mainly when they use the retractors on the distal part. I have seen a couple of radial nerve injuries because they use a human retractor and they just lean over that and then they compress. They usually recover, but they compress this one. And for me, as I said, nowadays I use it mainly on type C fractures. I don't use it on type A or type B. William has very good experience, as well as Juan Manuel Concha from Popayán, Colombia, doing this technique in type A fracture, but they both insist that the plate should be long and the reduction in type A and B fracture should be as anatomically as possible. Something that in type C fracture, you can usually do the bridging plating, which for me is easier. And I do agree with Eduardo, open reduction, internal fixation, those fractures, at least in my hands, are more predictable.
I think interestingly enough, our first paper highlighted the importance of having an understanding of anatomy and what that can open up for you as far as surgical approaches. And this is kind of the same idea, but in a different way. I think there's multiple ways to do minimally invasive fixation in the humerus shaft. Do you think that the described techniques here are still the best as far as surgical approach and anatomy at risk, or have you tried any of the other approaches or techniques?
Justin, I know the people, again, the people from Buenos Aires in Hospital Italiano and in the Hospital Churruca, also Miguel Sublin started to do some posterior MIPO on the humerus. And they have a couple of good articles, one in Techniques of Orthopedics and the other one, I don't remember the journal. But what they do is they identify the radial nerve in the proximal window in a posterior approach and then slide the plate from the posterior approach. I have no experience with those, and I think if I'm gonna do that, I'd rather see the nerve than do a small window and try to slide it. That's the beauty from the front. The studies from William Belangero as well from Miquel Videla show that the surface on the front of the humerus is really flat. So basically, you can slide the plate on it, and there's nothing else that you could find in. They actually what they did on the studies is they slide the plate and then they open the tunnel. And if you look at the tunnel, there's basically nothing in there. The disadvantage, Justin, is William told me that a few years ago, is that if you have some delayed union and you need to take the plate out, that is difficult because the plate is get with some tissues inside the holes. And actually, William was thinking having a plate with no holes in the middle and holes on the extremes of the plate.
Yeah, it's an interesting concept. As even the post-op radiographs you show with 2 screws on either side, whether it's from an anatomical constraint or because that's thought to be enough stability, to see that go on to healing is interesting, because I think historically we're taught that it's 3 screws or 6 cortices, a little bit more fixation than what you would see there. But that might not be possible with the anatomic constraints in that region.
Actually, when back in 2001, 2002, Bruce Iran, who's now in Atlanta, was at Pittsburgh at that time. He went to Brazil and saw William Belangero, so we started to write some papers together. And Bruce started, at that time, the LCPs were starting, and Bruce was using just one cortical screw to get the plates seated, proximal distally, and then 2 lock screws on each side. So 3 screws on both sides, and he published that on the Journal of Trauma a long time ago. And I know Bruce still uses some of the bridge plating techniques in Atlanta in his practice.
We do have another question. What about post-op protocols for isolated single extremity injury? Uh, and then is that different from alternative fixation constructs? So this approach versus something else.
Not for me, Justin. I allow them to do immediate range of motion, and use their arms as totally the same thing. And if I do an upper reduction and internal fixation, using absolute stability for type B or type A fractures.
And
I don't know, Eduardo, if you do something different.
Yeah, I think that we mustn't forget the biology of healing, no? So if we have if we are sure that we provided a stable construct, we have to put the extremity in motion, no? Same as for articular fractures, no? In lower extremities, we have to most quickly put weight bearing. Sorry. So yeah, I put them to move the extremity day one of post-op. No.
and then so this paper does demonstrate DCP implants that we don't really use anymore. Do you think that there's any difference there as far as the success rate? Is it these implants are stiffer? They have different properties. If we were going to extrapolate this to what we would use today.
I don't know, Justin. I'm still a huge fan of cortical screws. Despite having the LCPs of the new technology, I still use regular screws, cortical screws. If you have good quality bond, if I have bad quality bond, then I use definitely locking head screws. And as far as I remember, the series from Bruce Uran, who was using LCPs, was not very different from what William published with using DCP plates. But I don't know any study that compares both techniques, Justin.
Okay. We have a question for one of our previous papers, going back to our augmentation for proximal femur fractures. So the audience is curious if you were surprised by the results.
Absolutely surprised, Justin. It's funny what my partner, who is the main author, Carlos Solarte, he started our orthogeriatric center back in 2008 in Bogota, and he's very involved in fragility fractures. So he was the one who pushed us to do that study, and I was really surprised to see the results, because I thought I was a little bit biased, and I thought, it's gonna be better with the augmentation. But again, Michael, as I said, I think there's some bias, because if I go back and look at every single of those patients, the reductions were really, really good, and the implant position was really, really good. So I think there's a bias on that one. So, but at the end, it's not a bias. It's something that we should teach everyone. A good anatomical reduction, restoring the anteromedial cortex and putting the implant in the right position are key to the success of these ones. Would this technique be better in some patients, as you said, Michael? Probably for me, still very old patients and severe osteoporotic fractures, and in a patient that has already a previous fracture on the other side, or fixing, again, then probably I would use the augmentation technique. But I was really surprised, and I think
And so now that we're on the other side and the study's completed, how often would you say it happened that there was a fracture that you would have leaned towards using augmentation that got randomized to not being augmented, and then ended up doing just fine?
yeah, again, Justin, I think the key with the intertrochanteric fractures, despite all this new technology, probably go back to basics. is go and reduce the fracture, restore the medial cortex, the posterior medial cortex, the anterolateral cortex, as the studies recently published from the Chinese, and then get the implant in the right position. Probably that's the key.
Yes, I think, a unpublished secondary outcome is the reduction matters.
I agree with you. I agree 100%. It's no, I don't know, and I definitely know it's not ethically doable to see if you have a malreduction or a malposition of the implant, that if the augmentation will prevent the failure of those. But of course, that's something that we cannot do.
Some Well, I think we are out of time. I wanted to thank both Dr. Rodrigo Pesantes and Dr. Eduardo Carrillo for being present with us tonight, sharing some of their work and also some of the work that's important to them. We'll head back here just for a quick reminder that if you want to continue these conversations or potentially collaborate or discuss uh, topics with the rest of the AO community across the world, you can use the My AO app. Uh, and you can also use that to view the recordings if you ever miss them, or even discuss cases through this platform. So, with that, I would like to tell everybody thank you for attending this evening. I hope to see you next year.